So my first paper is a comparison syndesmotic malreduction rate following trans-syndesmotic screw fixation in ACR versus a PR type ankle fracture, a prospective analytic study. I have no disclosure. Syndesmotic injury usually occur approximately 50% simultaneously with ankle fracture. When we look into specific ankle subtype, for the supination external rotation type, they report around 40 to 45% with syndesmotic injury. But for the pronation external rotation subtype, they report at least more than 45% have syndesmotic injury. But they believe they have no exactly number because the incidence should be higher than this, but we have no available data. Syndesmotic fixation is recommended after we do anatomic reduction and fixation of the ankle fracture. However, syndesmotic malreduction has been reported, and approximately 50% based on CT scan. And malreduction of syndesmotic associated with the poor radiographic and functional outcomes. After review of the literature, only overall incidence of syndesmotic malreduction was reported, and there's no currently no comparative data of syndesmotic malreduction compared between ACR and PER type ankle fracture. This leading to our research question: does syndesmotic malreduction rate in SER is similar to PER type ankle fracture? Our null hypothesis: syndesmotic malreduction rate in PER is equal to the SER type ankle fracture. The purpose of our study is to demonstrate a malreduction rate of syndesmosis using simultaneously bilateral postoperative CT scan and measurement after trans-syndesmotic screw fixation between ACR and PR type ankle fracture. For surgical techniques, so all patients, we perform anti-ankle arthroscopy to make sure they have drive-through positive and significant injury to the syndesmosis. After that, we perform open reduction and fixation distal fibula by a 1/3 tubular plate and lag screw. In the patient who have posterior malleolar fracture, we will use a posterolateral approach, and then we fix the posterior malleolus with multiple screw or 1/4 tubular plate, and then we fix the distal fibula and syndesmosis. For syndesmotic fixation, in reduction part, we will use the anterior distal TPO fibula line, and by using a direct observation, and we stabilize and with the syndesmotic clamp. And then after that, we check the fluoro and also check the line until distal TPO fibula line to make sure they have no notching, they have no elevations, and then we fix the screw. After perform the surgery, we will do a bilateral CT scan post-operatively, and then we measure the syndesmotic malreduction. This technique has been proposed by Pinit Pisitgun from Iowa. So we use to measure the anterior and posterior lip of the distal tibia as the AB line, and then the AC line was perpendicular to the AB line. And then we measure the anterior part of the fibula. If it's far away from the AC line, okay, when compared to the uninjured side, more than 2 millimeters, this we call abnormal. If the fibula move forward, we will call anterior displacement. If the fibula move backward, we will call posterior translation or displacement. On the other hand, we also measurement on the medial and lateral displacement as well. We use the same line and then measure the inner part of the fibula from the AB line. If the fibula close to the tibia, we will call overcompression. But if the fibula far away from AB line, we will call undercompression or lateral displacement. Here was the result from the demographic data. We have 53 patients with the SER type injury, 15 patients with the PR type injury, total for 68 patients. They have no significant in age, male to female ratio, body mass index, and duration of the follow-up. Incidence of syndesmotic injury in SER type was 70%, while the PR type was 100%. Overall was 84% in all ankle fractures. Operative time was significantly higher in the PER type. So when we look into the syndesmotic malreduction as we described earlier, we have one from SER type, 1.8%, and we have 20% from PER type, and significantly higher in the PER type ankle fracture. For measurement, syndesmotic widening from the medial clear space, all patients have normal tibial fibular clear space after perform the surgery. average 4.0 in SER type and 4.8 in PR type, and no significant difference. When we look into the AP distance, you can see on the right lower bottom, there compared to the uninjured side, there was no statistic significant in both type of ankle fracture. And also in the medial lateral distance, they have no significant difference, both SER and PR type ankle fracture. For the subgroup analysis, when we look into the detail of the malreduction and in the SER type, there was anterior displacement. 3 of PER type, 1 anterior, 1 posterior, and 1 under compressions. So here's a case example. After we performed the surgery, you can see the fibula on the left side was anterior translate. And another case, you can see after perform the surgery, they have under compression on the fibula compared to the uninjured side. So syndesmotic injuries commonly occur than previous literature. Overall, 84% in all ankle fracture, and we found 70% in the SER type ankle fracture and 100% in the PER type ankle fracture. So malreduction of syndesmosis was common occur in PER type than the SER because in PER type, they usually have extensive damage to the syndesmosis as well as the interosseous membrane. So this leading to a closely unstable between the distal tibia and fibula, and difficult to make it right back in place and very challenging for anatomic reduction. So when you perform a surgery and reduction for the syndesmotic on the PER type, you must to pay more attention and carefully for syndesmotic malreduction. Limitation of our study, a small sample size on the PER type ankle fracture, and with no report on malrotation in terms of internal or rotation or external rotation of distal fibula. However, the strength in our study, we're using the same technique of syndesmotic fixation we call direct visualization by using anterior distal tibial and fibula line, and all surgery has been performed by a single surgeon. So we use the most reliable measurement method based on the comparative study from JBJS, and then we're using the bilateral CT scan simultaneously after the surgery. So in summary, the incidence of concomitant syndesmotic injury and syndesmotic malreduction rate following trans-syndesmotic screw fixation was significantly higher in PER type compared to the SER type ankle fracture. The malposition of distal fibula was likely to be displaced anteriorly and laterally or under compressions compared to an injury site. Thank you for your attention.